test of cervix was negative for intraepithelial lesion or malignancy. HPV genotype was also negative. The tumor marker so on the alpha FP, CA125 and other markers are normal. Only in gastroscopy and coloscopy we found 2 hyperplastic polyps on colon and on stomach. We already removed, and his pathology examination was normal. There is a CT scanner of the patient before the operation. The tumor on the left ovary. The size, the diameter of the tumor is about 7 centimeters. We did CT scanner for the thoracic, abdominal, and pelvic, and we found only there's no distant metastasis. We found only 1 tumor on left ovary, and the MRI pelvic also confirms the diagnosis of left ovarian tumor. And the patient was operated on April 21st, 2022. And with the diagnosis, intraoperative diagnosis is adult granulose cell tumor on a left ovarium with uterine fibroid. In the intraoperative checkup, we found the left ovary and the mass with the tan yellow and measuring about 7 centimeters in gross section, and so multilocular cyst with smooth external. And the most important that tumor limited only on the left ovarium, and no tumor on fallopian tube surface, and there was no surgical spin, no capsule ruptured, and no evidence of malignant cell in peritoneal washing and large omentum. This, and due to the intraoperative diagnosis is adult granulose cell tumor of left ovary was confirmed, and the surgeon will decide to do the total hysterectomy and remove both ovary and with uterus. And the patient was recovered very well and discharged after 5 days in the hospital. And there is pathologies of the patient with Dr. Lang. We did the histopathological examination, and we confirmed the adult granulose cell tumor and leiomyoma uterus with chronic inflammation of the cervix with narcocyst. And there is some picture of the pathology, and there is a hematocilin eosin technique. On immunohistochemical technique, we found positive with creatinine and CK and SMA, and another marker was negative. And there is image of immunohistochemical image for CK marker and SMA and creatinine. And the future, and we would like to discuss about the plan of the treatment for the patient, the classification of this patient, and does the patient need adjuvant chemotherapy or any other treatment, and what do we need to do the surveillance for the patient. Yeah, this is finished. Thank you so much for your attention.
Thank you. So I will share our PowerPoint. Wait a second.
So, thank you, Dr. Khanya, for presentation. It's a very nice case that are very rare. So, first, you'd like to hear from College of Kaohsiung Veteran General Hospital.
Okay. I
Thank you.
answer your question in this PowerPoint. The pathology classification of non-epithelial ovarian cancer. This is capture from the NCCN guideline. So you can see non-epithelial, we will majorly has germ cell tumor. Another part is the cystoscope tumor. And in the cystoscope tumor, the large proportion is the adult granule cell tumor. So it is not very rare in Asian people. And you can see the cystoscope tumor only about 3% in all ovarian cancer. And in the right lower corner, you can see the age distribution and the percentage. You will see cystoscope tumor is span a very wide age group. So even you older than 70 years, you still have a chance to get it. But the germ cell tumor is very young. But average is different with the epithelial cancer. In our hospital, every year, we only have 1% or 2% have this disease. So it's not very popular. It's only a rare cancer. I will provide this data to you, okay? So you can see in the right corner, you will see a dark granular cell tumor is the malignancy. For this question, do you have any other? Do you have any question about this?
No.
Okay, we see next slide. Next, does the patient need adjuvant chemotherapy or any future treatment? My question is no. Oh, because he's very indolent tumor, he very slow growthing, and according your report, this is intact tumor, no rupture, so he's the stage 1A ovarian cancer. So you can see the guideline is low risk. The guideline suggestion is observation. And because this tumor will, about 50% patient will secretion large amount of estrogen. So during the surgery, the uterus must be removed at the same time. So you do the right decision. And the follow-up is according to the pre-surgery tumor marker. The tumor marker, we will check the estrogen level and the inhibin A. But in our hospital, we cannot detect the inhibin A. So we only check the estrogen level. But according to your PowerPoint, you don't have the estrogen level before the surgery. So you only can check this. Because the inhibin A is not very useful in every daily practice. So a lot of hospital cannot provide this test, even in Taiwan. So for this question, I suggest just follow up, and you can check the estrogen level, because after menopausal estrogen level must be very low. If they increase, maybe it give you some hint for tumor recurrence. Do you have any question?
Thank you very much. I think very clearly from your presentation, you understand this case as well. So today, once we have chance to invite one expert come from National Cancer of Vietnam, Dr. Phạm Tuấn Anh. Could you please, Dr. Tuấn Anh, had any comments for this case and also that from suggestion from Taiwan College?
Yes.
Maybe.
At first, I agree with Taiwan expert. This is a very early stage, one eye and low risk. So the capsule is intact. So in my opinion, after standard surgery, after standard operation, I also recommend the observation only, and the histology is also indolent. So I think the prognosis is very good. Yeah. So but we need very closely monitoring, closely observation. Yes. I hear that you recommend do the estrogen level monitor to follow up recurrent rise, Professor. You recommend to do the estrogen level measurement, right?
Can you catch Dr. Phạm Tuấn Anh opinion, right?
Can you speak again?
Taiwanese professor, I would like to ask you that as I hear from you, you recommend us to do the estrogen and progesterone level, to follow up recurrent rise.
Okay. Show the next slide. This is
estrogen level. Yes.
Yes. This
I would like to add you the follow up.
So it's very benign behavior than others existing ovarian cancer.
Yes.
And we don't have any prevention can provide because you do the major portion. Mainly, we will remove for ovarian cancer. The best practice is do the complete staging surgery, but a cord-gonadal cell we cannot diagnose it before the surgery, so we will accidental finding in surgery. And at that time, we will remove uterus, but sometimes we will don't perform the lymphadenectomy because a lot of patients don't have a lymphadenectomy. So before in your pre-surgical CT scan or MRI scan, they don't show any abnormal finding in lymph node. We can keep this intact. So we just follow up this case only. And then we will do the regular, in the first 2 years, we will follow up tumor marker and the sonography every 3 months. After 2 years, we will follow up 6 months interval for 3 years. And after 5 years, we will regular follow up every year. But if this tumor recur, it will happen very later. So in this NCCN recommendation, you must follow up this patient as long as possible, because some patients will recur maybe 20 or 30 years later.
Yeah. So what's tumor marker you recommend for follow up?
I will do the tumor marker check because the pre-surgery, the CA125 is normal and the other is normal.
Yes.
So I will check the
Yes.
surgeon label only, and we will do the sonography to scan the long pelvis. If this is negative, if everything is okay, and every year we will do the chest X-ray to see any evidence of lung meta. If we don't have this evidence, I think just follow up is enough for this patient. And I will education the patient because when the tumor recur, the major part is in the abdominal cavity. So when they feel they often feeling abdominal fullness or others, we can do the sonography again to check any evidence of recurrence. So in this
Okay,
case,
understood. Yeah.
lucky, it just complete the necessary surgery, and we just provide the follow-up only. They don't need any adjuvant chemo or radiation therapy.
Understand. Yeah, understood. Yeah. Vâng, em cũng muốn nói qua lại một chút về cái quan điểm của giáo sư Đài Loan để mọi người cũng thống nhất là cùng một cách hiểu chung ấy, thì là giáo sư thì tức là đưa ra một số những slide thông tin là về đây cũng là một cái khối u mặc dù là hiếm gặp ở buồng trứng nhưng mà nhìn chung là tiên lượng tốt và nó indolent, tức là tiến triển chậm. Ở bệnh nhân thì giai đoạn rất là sớm và u nó chưa phá vỡ vỏ, và do vậy là cái cũng không khuyến cáo là điều trị bổ sung thêm hóa trị và chỉ có theo dõi đơn thuần thôi ạ. Và trong 2 năm đầu thì theo dõi mỗi 3 tháng, và những năm sau thì theo dõi mỗi 6 tháng, và sau 5 năm thì theo dõi hàng năm. Và cái tumor marker mà em có hỏi về cái estrogen, nhưng mà có vẻ như là giáo bên chuyên gia thì họ cũng không có cái ý lúc mà em nghe, hình như là nếu mà cái tức là ở cái tuổi mãn kinh thì thường là estrogen thì nó sẽ thấp, nhưng mà cái khối u này nó có thể nó liên quan đến estrogen đấy, cho nên là nhưng mà em hỏi lại thì cũng chuyên gia chưa trả lời rõ và cái việc này thì chỉ chủ yếu theo dõi bằng CA125 và các cái phương tiện về chụp chiếu đấy. Và thì không biết là các thầy các anh có bổ sung gì thêm nữa.
Cảm ơn Tuấn Anh. So thank you very much. Actually, Dr. Tuấn Anh, expert on this disease and also inter-cancer disease in general. He explained us about that your idea how to manage the patient as well. Actually, the patient underwent the surgery like from the radical resection, so it had stage 1 low risk of the recurrent. And of course, he explained how to follow up the patient for first year, third year, and also in next 5 years as well, and also for some, clinical examination or maybe from diagnosis, imaging examination as well. And from today also, we invite Dr. Lang. He actually is the chief of the histopathology department as well. Dr. Lang, you are still available here, right? Do you have any comments so far on that thing?
Thank you, Dr. Ching, for presentation about histopathology examination. I do agree. This case, I don't give our diagnostic adenocarcinoma cell tumor because the selenium tumoran is other polygonal cells, scant cytoplasm, and the uniform group nuclear cord-gonadal shape, and architecture which various, including leafy, trabecular, and cord-gonadal. I don't see any sign of leukocytes and the mitotic index is very low. One or rarely seen in 410 high few. So for immunohistochemical examination, the selenium tumoran is positive with congratulin and CK SCAT and So I give the diagnosis, granular cell tumor. I don't see the invasive, the ovary capsule in limit on the ovary. So I confirm my diagnosis is stage 1A. For the FIBO 1A. So I give for the clinician and oncologist this detailed information. Thank you.
Thank you so much, Dr. Zilang. Actually, from the clinic side, we invite some doctor from the oncology department and also from pathology department as well. Do you have any comment and suggestions so far on that case? Dr. Cao Mẫn Thấu, for example, or Dr. Nguyễn Đạt.
Hello everyone, I'm Dr. Thấu from Oncology Department. Actually, I'm a surgeon, gastrointestinal surgeon. So I'm a assistant surgeon for in this case. Actually, during in operation, we on behalf of Professor Sun, I can say that the margin is very clear, the tumor, and the patient achieve R0 resection. So we don't see any evidence of the tumor metastasis in the sigmoid colon or larger omentum, and no evidence of the positive in peritoneal washing. So I think, in my opinion, the patient don't need to receive adjuvant chemotherapy. But you know, as professor from Taiwan and Dr. Phạm Tuấn Anh said, the patient also have to follow up a very long time, because some research they report that maybe patient can recur lately, maybe 20 or 30 years. So we have to carefully follow up. I have two questions about first. For example, the first one is about the mutation. Does this patient need any further pathology test for mutation, for example, FOXL2 mutation? And the other one is in some report they said that maybe the patient have to follow up the malignancy in the breast cancer. I mean, in the opinion of Dr. Phạm Tuấn Anh, he recommend estrogen follow-up. So I think the patient should follow up also the for ruling out the breast cancer in follow-up. And the second question is, if the tumor occurs maybe several years ago, next 7 years, so in your opinion, can that we need to perform the total omentectomy or lymphodectomy in this in the futures? Thank you so much.
For the first question, because this tumor is very rare, so we don't have any data about any typical mutations related to the prognosis of the treatment. So we don't regularly provide the genomic testing for this case. And for this case, because a lot of patients don't have major, over 90% case is stage 1A. So they seldom have lymph node metastasis or intra-abdominal carcinomatosis. So even in the first surgery, we only provide the hysterectomy plus the bilateral sublingual oophorectomy is enough for this patient, because the adult granular cell have a typical they can secrete extra amount estrogen, so they can induce a second cancer, is the endometrial cancer. The patient will have the postmenopausal vaginal bleeding, but in this case, they don't have this symptom. And the final pathology show and the imaging is normal. So I think the surgery estrogen level may be the normal. So we don't worry about this. But in Asian people, the breast cancer incidence progressively increasing. Maybe we consumption too many animal products, so maybe they have other issue. And if the patient recur later, we will think about where is the recur site. If we can provide a surgical resection, we will do this first. Then we will provide adjuvant chemotherapy for this. And adjuvant chemotherapy, we can use the germ cell tumor regimen or epithelial chemo regimen. They can provide, but we don't suggest to perform the chemotherapy right now because for this patient, they don't get any benefit from the adjuvant chemo. We will keep this adjuvant chemo for later when he recurs. We can use it because if we use this first, after the recur later, we don't have an HR regimen can use.
Thank you so much. Right.
So thank you so much. Seeing right now the Dr. Khánh on behalf of the patient family, also the surgeon. Do you have any questions so far? Dr. Khánh, please.
Thank you very much for to all of you to have this meeting. We as conclusion that to answer the question that we don't need to do the adjuvant chemotherapy for the patient, and we do only the intensive observation for the patient. So that is on behalf of the patient. We are very happy to hear that, and we would like to say thank you very much for all your attention and your help to do this meeting, and I think we have very successful meeting, and if in the future we have any future problem or questions, we would like to contact you guys again to have more recommendation from you guys. Thank you very much.
Yes.
Okay, just one thing, remind you, Dr. Khánh, at the college from the, Taiwan suggest, the case that might be the next 30 years. So this year, your mother get, 61, right? So when your mother get maybe 91, okay, you had to check up again. No problem. Okay. So again, thank you so much first for college from the Kaohsiung General Hospital for very nice meeting today, right? You learn a lot from this case as well, and also you get advice from you how to follow this patient, also how to manage the patient. Maybe you can meet, in the future, some case like this. And also thank you very much, Dr. Phạm Tuấn Anh, come from National Cancer Hospital as well, to give us some advice and also comment for this one, and explain us very clearly and how to follow up the patient, and also for some prevention for the future as well. And thank you, Dr. Lai, the chief of the pathology department as well, and one college from Việt Đức Hospital to join this meeting. And again, thank you very much, on college from the Kaohsiung General Hospital. And we are looking forward to meeting you again for some special case that, very good opportunity for us to exchange, experience. And also for some special case that we learn from you. And of course, in the future, you hope you can get, like a face-to-face meeting, right, to discuss more detail And also we learn not only for, that case, but also in general surgery as well. And again, thank you very much for your kind participant today's meeting, and which all of you stay safe and see you soon again next time. Thank you.
Thank you.
Thank you.
Okay, học ứng nhiều. Học ứng nhiều,谢谢你，再见。
谢谢。
谢谢。
Thank you. Bye bye.
Cảm ơn bác sĩ Phạm Tuấn Anh lần nữa nhé, bác sĩ Lánh, bác sĩ Thấu. Đặc biệt cảm ơn bạn Trà đã giúp cho cái buổi hôm nay tổ chức thành công. Tôi hơi trầm trọng một chút